Can you hear me now? Perfect. Thank you, Chief. All right, guys, we'll get started. It's 9:01. We are live in Arley, Alabama at the Winston County Rescue Squad. Sweet. Thanks for hosting us today. Really appreciate it. Doing some great work out here. We've actually had some interesting calls that we'll talk about later during the skills lab. But we are here from 9 to 11. I'm going to do a quick talk about some 12 leads and a few cases in resuscitation. And then Dr. Adams can talk about some respiratory emergencies. If you have any questions or comments within reason, please just let us know. Within reason being the key phrase. So, Alabama EMS Challenge, we're glad to say that we're sponsored by Alabama Fire College, and I promise that I will show a picture of their leadership. And then there's another photo that some folks don't know him from his youth as well. So, but I'm going to get in trouble for that one too, but that's okay. So EMS Challenge, just for those that are unaware, we started this about 10 years ago. It's physician-led Con Ed. This is not a refined program. We do have a YouTube channel, but the goal of this is to bring practical physician input back into EMS. 30 years ago when I was doing pre-hospital work, there seemed to be more physicians in the field. We're trying to regrow that at UAB by integrating our residents and our fellows in the pre-hospital world. We are also now, thanks to the support of our department, able to get first and second year med students exposure to EMS. So hopefully when these guys grow up and become leaders in the healthcare system, they'll help us integrate, bring EMS into mainstream healthcare and fix some of the issues that we have with billing and things of that nature. So that's one of the goals of EMS Challenge. I won't read what that is, but that's who we are. And if you can read that record, you know why I said that, but that's my inappropriate humor and I'll keep moving. So, this program won't be as exciting as the last weekend at NASCAR, but I hope that won't put you to sleep either. Cool. So follow up for the rest of the year. We're at the Rocket City EM Conference tomorrow doing a lab from, I think, 1 to 5. And the 22nd of May, we're up at Aero Region 1. We should know the location of that venue, hopefully by tomorrow afternoon. Back in June, we're at Birmingham Fire and Rescue Station 1. And June 26th, we're at Sand Mountain Park. I think that's Albertville. Is that correct, Chief? Someone says yes. Very good. Yeah, cool. Yeah. July, we're not going to do anything. We have 13 new residents coming in. We're going to do some educational stuff with those guys, get everything set so we can start back hot and heavy in August. The first class in August will be at the Colonnade in Birmingham, sponsored by the Alabama Power Company. So that should be pretty good for us. So friendly reminders. First off, anybody here know who this guy is? No one's going to know this except for Chief Ward. That's never mind. All right. I thought it was funny, but nobody got it. So reminders on your 12 leads, when you document those, please document your 12 lead in your narrative. When your charts go to the state, the rescue exchange, a lot of times the EKGs don't follow them. And for hospitals, that's paramount because that way they can get that time, that first EKG interpretation that you guys see. And that's good for us because now we have hospitals and health systems that want to see our documentation. So that leads to more data exchange, which means better access to billing and also understanding of what's going on with your patient. So that at some point in the future, when you log in on your laptop, if you're doing electronic records, you can say, oh, this is Mr. Smith. His old EKG always looks like this. Now I have a new one. You can compare. So that's where we're going with that. So your 12 leads, I would in your narrative document the time, the rate, the rhythm, and STEMI or no STEMI. Nothing fancy, right? So 905, sinus rhythm is 74, no STEMI. That's all you got to put. Capnography, if you're ALS licensed in the state of Alabama and you placed an advanced airway, you got to have capnography. I can tell you right now for legal reviews, if you got somebody that has an iGel or an ET tube and you have access to waveform capnography and you don't document that and that ever goes into court, that is going to end up biting you, okay? It's a patient safety issue, whether it's an iGel or an ET tube. My advice is when you place your ET tube or your iGel, you put that you see the waveform and the number, you document in your narrative, see waveform capnography at 34, 96, at 7, whatever it is. And then when you relinquish care of your patient, either to another transporting agency or to hospital, your last line of your narrative to prove your airway was still good is, I got waveform capnography at whatever number, okay? There's no way to argue with that. It's objective data. I mean, obviously you can put, when you place an ET tube, I got breath sounds, no epigastric sound, the patient gets better. You put all that stuff, but you got to put capnography, guys. Just trust me. Epi doses, my thoughts on this is you get first milligram of epi in cardiac arrest as quick as you can. The second dose is based upon what's going on with the patient. Most places that I work with now, we're spacing out to at least every 5 minutes, sometimes even farther. But we know that first dose epi, time to push in cardiac arrest is super important, fixes a lot of problems for patients. Second dose depends on what's going on with the patient. And then you kind of use your clinical judgment on that. But first dose, pretty quick. Narcan, there's a lot of public use Narcan and law enforcement Narcan, which is fantastic. But for us EMS providers, my advice, if you're using Narcan, we're using it for somebody who is not breathing, not ventilating on their own. And we're using it after we've done passive O2, nasal cannula, high flow with the OPA or MPA, and we ventilate them. We ventilate for a few minutes, then we push that nasal Narcan so that when they wake up, if they wake up and it was an overdose, they wake up happy and polite and friendly. Unlike the ones that we just look at and they're that blue, they're breathing 3 times a minute, we push Narcan, we back up and we just watch them, right? Those guys wake up. If they wake up agitated, aggressive, violent, we have more problems. So ventilate your patient before the Narcan. My thoughts, if you give a nasal Narcan, you give that 1 dose after you ventilate for a while. If they wake up, great. If they don't, I'm not going to repeat it, okay? The goal, the reason we give Narcan is to reverse respiratory depression or arrest. If you can ventilate your patient, so be it. Ventilate them, okay? Now, if I got somebody that's 4'8", 380 pounds with a beard and no teeth, and I look at that patient, I go, holy crap, there's no way to ventilate them with a BVM. It's going to be complicated. I'm going to hit them with Narcan first. Does that make sense? Because I want them to breathe, right? I'm hoping that Narcan works. I'm going to try to ventilate them, but I know it's going to be complicated. All right, cool. Narcan and cardiac arrest. My advice, don't waste your time. Remember, Narcan will make you breathe if you take too many opiates. It also increases your blood pressure. If I got somebody in cardiac arrest, I should already be ventilating them. I should be oxygenating them. I should be doing chest compressions. And the first drug I give in cardiac arrest is probably epi. So epi in a bag will fix same things Narcan can fix. So I probably would not give these folks Narcan in cardiac arrest. Now, if you got the Lucas chewing, you got your access, they're intubated, you're given your first round of drugs, and for some reason you think it's an opioid overdose, big fentanyl exposure, and you as a medic want to give a dose of Narcan IV after the I won't say basics, after the primary stuff is done, more power to you. I won't argue with that. But don't waste your time on Narcan up front. Solumedrol has been out for a while now. It's a great drug. Remember, 2 patients be advised. If they're pregnant, probably shouldn't be giving them solumedrol unless you think they're dying in front of you. And if they're diabetic, we probably should not be giving solumedrol because it raises the blood glucose, and unless you think they're dying in front of you. And at that point, risk to benefit, all bets are off. Give the solumedrol to those folks. We can fix those things at the hospital. All right. Toradol, great drug, not an opioid. You're not going to get somebody hooked. But remember, Toradol is really bad for people's kidneys. And what type of patients have kidney disease in Alabama? Anybody know? Diabetics? Folks with kidney disease, I'll give you that one. What other kind of patients? Sir, geriatric. Heck yeah, yeah. My statement of this is kind of funny. It's anybody. If your license plate on your car says Alabama, you probably got some kidney problems, right? Because everybody's hypertensive, diabetic, all right, or getting older. But definitely old people, mature folks over 60, don't get Toradol. You'll kill their kidneys off. Pregnant patients, don't get Toradol, okay? Toradol is great for isolated extremity injuries, pain, and young people, all right? But Toradol can be bad. And then death in the field, I don't like to use that phrase. I prefer to say that we don't get orders to call a death in the field. We get orders by EMS to stop resuscitation, and that just kind of helps us out in a medical legal sense, because in Alabama, to pronounce someone, it's either the coroner or medical examiner or a physician. So as an EMS provider, what you're really doing when you call and get your orders not to resuscitate somebody is just that, not to resuscitate. My thoughts are in your narrative that you don't put phrases like time of death, pronounce deceased. You put talk to med control at 9:10, orders received to stop resuscitation, and then put that time. Law enforcement can use that time as the time of death. The coroner can use it for the time of death. The primary care doc that's going to fill out the paperwork can use it as time of death, but it just keeps you out of that loop with the family, the legal, the coroner, all that stuff. So my thoughts on that. Thank you for almost smiling. Good. All right. Remember, when you apply for your state license this year, if it's your year, you got to have a quality improvement plan. Super important that you actually do that. I think it does two things. It protects your patients. It allows a way to educate your providers and get follow-up. You can kind of look for trends of mistakes and errors. A couple of years ago, we were pulling up adenosine. It was hard to find, and the only one you could get looked just like epi in the 1 to 1,000. And there were a couple of cases where folks were given adenosine IM for anaphylaxis instead of epi because the files look the same. So you pick those things up when you have a quality improvement program, protects your patients, and it also protects the well-being of your staff, the crews, you guys, and me, right? So if you make a mistake and don't know it, and you make it 7 times, when you realize you made that mistake, you're going to feel bad about it. Versus if you just make it once and somebody tells you, it's like, oh, well, crap, I'm going to do that again, right? So quality improvement, super important. If you need help with that, you can reach out to BRIMS. You can email us. We can send you a template. You can use that. You don't have to. It's just an option. But I'm happy to come out and help with that, or get one of my docs, residents of UAB to help with that, for you to set up your own quality improvement plan, okay? What is that? Inappropriate. Oh, okay. Semi-funny, kind of. Unless you're in court, right? Nothing's funny in court. You can't make them laugh in court, just saying, for a friend. Yeah. All right. So certificates in the room, you can scan the QR code online. It's in the chat box. You can always email us for your Con Ed. We can give EMS, nursing, or physician Con Ed credit as well. All right. So 12 leads. Let's talk about 12 leads. So you can talk about vectors and angles and all those things. For me, a 12 lead is a screening tool. It's a way for you to look at a patient, determine is there some kind of madness going on that you need to manage, okay? It's not the end-all, be-all. You guys and me as an ER physician, we don't have to understand what a left vesicular block is, all those things. Well, I guess as a doctor, I should take that back. I should understand that. But the point is, the 12 lead should screen patients. Are they sick or not sick? And should I manage their rhythm and their rate at this point? So I look at it pretty simple. I look at it as, are they too fast, too slow, or okay? Too fast, I'm saying, is it wide or narrow complex QRS? Is it regular or irregular? American Heart does it that way. I kind of like American Heart's too fast algorithm. Too slow, 3 things I think about if the rate is too slow, and I'm using 50 to 150 is my normal rate, or 50 to 140. So rates less than 50 is either going to be drugs, calcium channel blockers, beta blockers, electrolytes, or electrolyte, which is potassium, right, hyperkalemia. And the other one is ischemia, a heart attack, a STEMI or an NSTEMI, bad heart issues. Everything else you can pick up in your primary exam, right? So the 6-month-old that is pulled out of a bathtub, you get on scene, that is blue, has a heart rate of 50. What's going on with those guys? What caused their bradycardia? Respiratory, yeah, so they can get O2 and ventilation. That hopefully will fix that, right? The 30-year-old dude shot in the chest who's talking to you, calling you mama names, heart rate's 140, then it goes to 120 to 90 to 60 to 30. What's going on with him? Yeah, he's dying, hypovolemia, right? Yeah. So those things you pick up, right? The things you can't pick up in your primary exam is drug overdose, intentional or unintentional, hyperkalemia, or ischemia. And your 12 lead gives you that. And then there's things that are okay-ish. The rates between 50 and 150, and those could be something or nothing. Those are the ones that will bite you sometimes. Those are the ones that you got to look at a lot of EKGs. So if where you're working right now, you're not seeing 40, 50 EKGs a month, you got to go online and look at more. Okay, it's just like IVs or anything else. You got to do a lot of them, or you don't get the skills down. And if you're like me, some days I've worked several days in a row, and it's 2 o'clock in the morning. I haven't slept in a day or two, and I got this weird EKG. If you haven't seen a lot, you're not going to be able to pick up the things that kill people, and you're going to feel bad about it. Know how to calculate a rate. I won't dive into this deeply. I use the box method, QRS to QRS, 300, 150, 175. I start thinking about going fishing or watching a movie or having dinner. When my mind comes back to me, if I'm still counting boxes, it's too slow, right? You got to understand the intervals. So you got to know what a QRS looks like. So you know if it's a wide or narrow complex. What does a long PR interval tell you guys? First degree heart block, right? Textbook tells us all the time. What do we do for first degree heart blocks? Anybody know? Nothing. Yeah, right. So yeah, for me, it's like, nah, I don't really care. But I say if somebody's got a wide PR interval, I start thinking hyperkalemia, and that can kill people. First degree heart block doesn't really scare me much. Cool. QT interval is important because a long QT interval can lead to torsades. We carry medicines that we give in EMS every day that can lead to a longer QT interval and can make things worse. What drugs can you give a patient in the field that prolongs the QT? Zofran, yeah. Benadryl, right? And we used to do how doll do it, or hound dog, as we say in the big city of Birmingham, metropolis. Hound dog, sorry. All right, so EKGs, this first one, can y'all see it okay? Y'all can always move closer. I don't have COVID and I don't spit too much. So. All right, too fast, too slow, okay. I say the rate's okay. If I do the Mox method, I'm 300, 150, 175, so around 70 to 75, right? The machine reads the same. I trust the machine's numbers. I don't trust what they write on the right side, all right? So rate's okay. So now I'm gonna start looking for injury patterns, and I'm looking for ischemia, STEMIs, things that we can fix, right? So I'm gonna look in a kind of a root memorization. I'm looking lateral at 1, AVL 5 and 6. I'm looking for ST elevation or ST depression, T-wave inversion, right? Any two leads that have ST elevation is a STEMI. 2, 3, and AVF is inferior. And again, two leads with ST elevation is a STEMI. V1 through V4, those are your septal or anterior leads. Elevation there in any two leads concerning for a STEMI. Posterior leads, or I use V2, V3, and V4. Some folks use V1 through V4. But T-wave inversion, ST depression, concerning for a posterior infarct. Some people teach about doing a posterior backside of the EKG. I don't do that stuff. If I got somebody that has symptoms of acute coronary syndrome, they're an older person or even a young person, chest pain, sweaty, diaphoresis, and I see this, that's enough information for me to say, don't care about the posterior EKG. That's enough. I'm calling cardiology. That is a STEMI equivalent. They're calling TCC, and I put them in the system. Okay. The last place I look is lead AVR. Years ago, we learned that AVR was really a screening lead. If you're up in one, you should be down in AVR and vice versa. I know my leads are on correctly, but elevation in AVR and depression anywhere else in an injury pattern is concerning for a left main or right main. So if I'm up in AVR and I'm inverted 2, 3 in AVF, got a proximal big right coronary. If I'm up in AVR and I'm down in 1 AVL or 5 and 6, then I got a proximal left main coronary issue. All right, so I go through all that. The next thing I do is I look for intervals, look my PR, my QRS, my QT. If that looks fine, before I put this back down, I go back one more time and I look for an injury pattern because some days I'm really tired and I don't want to miss a STEMI. Cool. If I'm looking at lead 2 and my QRS complex is wide, now we're going to left bundles or right bundles, right? So I'm gonna go over and look at lead V1. And I'm looking to see, do I have a downward deflection or an upward deflection? A downward deflection is a left bundle and upward is a right bundle. And there's some tricks we can use to determine is that left bundle or right bundle really ischemic or not. It's called scarbosis criteria, right? So things that cause a left bundle branch block, chronic hypertension, okay? Obviously acute ischemia can do that, all right? And then underlying heart disease, cardiomyopathy, folks have had issues in the past. Anything that slows conduction through that left side of the heart is going to make that QRS complex get wide because the slower the electricity goes through there, the longer it takes, it makes that QRS complex get pretty big. So the slower it goes through there, the wider the QRS complex. Right? What does a left bundle branch block tell you about a patient if they have one? You know they're going to have heart disease, right? And they have some kind of heart problem already. So that already ticks them up in your brain to think, okay, chest pain, left bundle, even if the left bundle doesn't look scary, I know they have underlying heart problems. So this is a significant patient. So QRS should be greater than 120. And then I look at V1 as a notch going down. There are a lot of ways to define a left bundle. Cardiology can tell you all kind of things. There's sometimes I call and I say, hey, I got this guy with a left bundle, no scarbosa. And the first thing they tell me is that's not a left bundle. That is a fascicular block with a something, something. And in my mind, I'm thinking, yeah, I'm on a Coke right now. Thank you very much. Come see the patient, right? Again, for you and for me, an EKG is a screening tool, all right? And we're getting a screen to say is a left bundle or right bundle. So we can use something called scarbosis criteria to say, do we activate a cath ab? Do we call TCC? Or do we just watch and repeat that EKG to see if it changes? So YQRS, downward deflection in V1. So the pearls for this, again, if they got a left bundle branch block on 12 lead, you know they have underlying heart problems. Those folks are prone to having dysrhythmias if they have bad heart failure. They're also prone to having underlying ischemia, right? So it should make you very uncomfortable with that patient. Scarbosa's criteria is, there's a couple ones out there. There's the modified, there's even a new one out that came out a couple of years ago, but I use the original criteria, which basically says that ST elevation and the direction of the QRS complex in the left bundle is concerning for a STEMI every day. ST depression and V1 through V4, like we talked about, in a left bundle that is going down is concerning for a STEMI every day. The gimme that we get is discordance, right? So in V1 through V4, if the QRS complex goes one direction, the T wave goes the other direction, instead of getting one little box, you get one big box. So you get a little bit more space there, right? So discord is good. That kind of shows you that you can see a normal left bundle there on the left versus a ischemic ST elevation anywhere. Left bundle, right bundle is concerning. For V1 through V3, ST depression, T wave inversion. Usually you see that T wave inversion. Sometimes you don't. Concerning, the gimme you get is you got to have more than one big box of discordance there. And that's a joke for Chief Ward. I know. I'd love to hear you get upset with me. So this 12 lead here, I say the rate is okay. I'm gonna start looking injury patterns. I'm gonna look at 1 AVL, 5 and 6, 2, 3 and AVF. I go V1 through V4. I go over, look at AVR. It's opposite of 1, right? And I look at my intervals. Peer interval is good. QRS is wide. So we'll go over to V1. I see that I got downward deflection. It's a left bundle. And if I look at V1 and V2, I got ST elevation. But with Scarbosa, because my QRS complex goes one direction, my T wave goes the other, it's not more than one big box, not a STEMI. Okay. If my patient is still sitting there, my chest hurts, I'm sweaty, I'm still concerned, right? They're still going to get oxygen, they're going to get the aspirin, all the therapies, but the EKG is reassuring in the setting of a left bundle. Okay. If your eyes are crossed, that means you haven't looked at enough left bundle branch blocks on 12 leads. Okay. My eyes are kind of crossed too. Yeah, me too. Yeah. All right. So this one, too fast, too slow, or okay. Machine says the rate's 68, so that would be okay. If I count boxes, I'm 300, 150, 100, 75. So I'm saying about 80-ish, but either way, it's okay. It's between 50 and 150, right? So rate's okay. I'm gonna look at injury patterns. 1 AVL, 5 and 6. 1 AVL got T-wave, ST depression. It's concerning, but not a STEMI. 5 and 6, I got ST elevation. Makes me uncomfortable. That's a STEMI, right? I'm gonna go look at 2, 3 and AVF. I got elevation in 2, 3 and AVF. I go V1 through V4. V2 has that posterior look on it, but it's only one lead, so concerning, but not a STEMI there. AVR is opposite of lead 1, so that's good, not elevated. I go to lead 2. Peer interval is good. QRS is a little bit wide, right? So that is a left bundle. And even with Scarbosa, elevation is a STEMI. So 5 and 6 buys in the cath-lab. Leads 2, 3 and AVF is discordance, and it's actually big enough that it will make me uncomfortable too. It's almost one big box. But the machine just reads the left bundle and quits interpreting. So if we look at that, yes.
So lead 2, would you call that concordance?
Lead 2.
Limb lead 2.
Yes.
Okay. But I got you.
Yeah. But lead 3 in AVF is discord, right?
That's right. So I guess the question is you need to apply Scarbosa, you need to have concordance on the ST elevation. You need it in more than one contiguous lead.
Yes. Yes, you do. And you've got that in V5 and V6. Do that. Cool. All right. All right. So this one, too fast, too slow, or okay. I'm gonna say the rate's okay-ish. I'm gonna look at leads 1 AVL, 5 and 6. It looks funky, but not a STEMI. I'm gonna look at 2, 3 and AVF. I got T-wave inversion, concerning, but not a STEMI. I'm gonna look V1 through V4, and those deep T waves there with ST depression should make you uncomfortable. You should be sweaty. When you see that, you should be moving to your patient, asking more questions, making sure they got pre-oxygenation, start thinking about good history, drug allergies, right? I look at AVR, it's opposite of 1, not really elevated, so it's reasonable. I'm gonna go over and look at my intervals. Peer interval's fine. QRS is a little wide, so I'll go over to V1. And this time I got a Y QRS and that it points up. So now it's a right bundle branch block, right? Cool thing with the right bundle branch block is we know that by definition, we're going to have these posterior changes V1 through V4. So now the EKG went from super concerning to more reassuring. However, if my patient still looks like dirt, I'm still concerned, I'm still making phone calls, but that is normal in a right bundle branch block. Okay. Cool. What things can make you have a right bundle branch block? Anybody know? Anybody care? Nobody cares or knows. I like this. Nobody's going to say. Anything that jacks up the right side of the heart. So chronic hypertension, COPD, okay? Anything that causes increased right-sided pressures makes that right heart swell, and that conduction of the right side of the heart be slower, okay? Anything that jacks it up, all right? So for me, if I see somebody with a right bundle branch block, I think about things that make it acutely. And the most common lethal thing would be a pulmonary embolism. So if you get a PE, you get increased pressures in the right side of the heart. So you'll see AFib and you see a right bundle branch block. So if I got a young lady who smokes, right? She's got a swollen leg. She's hypoxic, tachycardic in the 140s, and she's got a right bundle. She has a PE. I can get imaging at the hospital, but if I see her in the field, she's got a PE to proven otherwise, right? Cool. Right bundle branch block. Cool. This is just a slide I show. It talks about locations of injuries. And yes, you can learn your vectors and how to do all that. Learn it, understand it, grasp that concept. But then if you're like me, you got to relearn it every 6 months to a year. So for me, I do better at the root memorization. I got a pathway to look at every EKG the same, so that way I don't miss something. And then if I have to think complicated about this EKG, I can go back deep into my brain and pull those vectors out. But I should be able to pick up STEMIs right off the bat cold. No. So my point to this slide is that do not trust the machines. I know folks online are probably sick of seeing this. You as a medic in Alabama should better read your 12 leads. If you can't, find some help. You can use EMS Challenge, the YouTube. If you don't like that, you want to offend me, Wave Maven is a good source. Life in the Fast Lane is an EMS Gear 12 lead online module. Rebel EM has some good stuff, but look at those things. I'm telling you, if you're not doing 40 to 50 a month, you're not doing enough. That's just my inappropriate humor showing you why we don't trust the machines. All right. And then for the younger generation that has no clue what that stuff is, there's this series that told us that machines were bad too, right? Cool. Thank you. All right. First case, lift assist. Patient passed out and you help get her up. She doesn't feel well. You get on scene, her pulse is palpable, but super fast. What are you going to do for this chick? So she's looking at you laying on the ground, you feel a radial pulse, and it's too fast to count. You can't do that math in your head. What are you going to do for her? Yeah, throw on the monitor. Yeah, quick and easy, right? Yeah, throw on the monitor. Hey, why don't you throw some O2 on her? If it's too fast there, I'm thinking pre-oxygenation, okay? Monitor shows free lead. That's what you got. What do you think is going on? Blood pressure is fine in the 140s over 70s. Heart rate is in the 190s to 200s. Sats are 98%. Always get an AccuCheck, get a glucose on them, right? Yeah, SBT, yeah. Who's drinking a Monster? You drinking a Monster right now? Okay, yeah, I like the purple Monster. Yeah, so all kind of things out there can cause folks to have SBT, Monsters, Red Bulls, Adderall. A lot of folks do it. Cocaine, meth, right? You can be old school and just do coffee as well, right? I think that's a Denny's commercial from a long time ago. I probably no Denny's around here anymore. So I'm gonna sit her up, make sure she's got good oxygenation on her. I've got my vital signs. I'm 3 leads on her. I'm probably gonna do a quick 12 lead on this girl as well. All right. Then I'm gonna start thinking about therapy. So that's her 12 lead. I say, is it too fast, too slow, or okay? Obviously, it's too fast. If I do my box method, 300, 150. So I'm between 150 and 300. So way too fast. All right. Is it narrow complex or wide complex? I would say narrow complex, right? Is it regular or irregular? Yeah. And how do you confirm it's regular? What do you do? Yeah, I can't do all that without my glasses. So what I do is I touch the patient. I reach down and grab their wrist or grab their neck. All right. Grab their groin. That sounds inappropriate, but if you gotta do what you gotta do, right? And feel the pulse? Is it regular or irregular, right? When you get rates above 180, 190, sometimes it's hard to tell. So I'm gonna look at that. I'm gonna say, yeah, it looks pretty regular. And I'm gonna reach down and feel the pulse. That's regular. So if somebody already said it, this is SVT. So what are you gonna do for this chick? Can't say chick, this person. Vagal. How do you make them vagal? What do you do for vagals? Yeah, blowing a syringe, blowing your thumb. Used to tell people a lot of times to bear down, but folks sometimes have accidents, on your stretcher, and that's not cool. So yeah, yeah, yeah. It's hard to do that second part sometimes. The older you get, dude. Okay. So yeah, vagal maneuvers. You can go online. There's some other tricks that you can do as well that are complicated, where you have them sit on the side of the stretcher, throw the feet up, lay. I don't do all that. Yeah, yeah. So that's for me. They're blowing on their thumb, blowing on a syringe. Pull out a 14 gauge IV. Let them see that, things that make them uncomfortable and scary, right? And kids, the things that fix SVT for the most part is a rectal thermometer. Okay. I'm not saying do rectal thermometers on your patients in the field. That'll get you in trouble, but it will break SVT. That'll make you vagal. On this 12 lead, if you look in AVR, classic SVT or AVNRT, they call it now, is you're up in AVR, narrow complex tachy with some lateral T-wave inversion. That's classic SVT. Most of these folks are fairly stable. All right. So you can try your vagal maneuvers and things of that nature. Right. We've already talked about that. It's usually a loop re-entry. So you give what drug if vagals don't work? Adenosine. So are y'all doing 6, 12, and 12 or 12, 12? And yeah. So
We do 6.
6, that's fine. Yeah. In the ER, I'm doing just 12, just one time. Just it seems to work better, but 6, 12, and 12 is fine. Key points to this is you want to make sure this is a regular rhythm. American Heart says you give it to Y complex tachyes that are regular, that you suspect SVT. In the hospital, I do that sometimes. My advice for outside of the hospital is that if it's a Y complex tachy, that you're calling that VTAC. And if it's VTAC and you treat it like SVT, somebody can die, versus if you call it SVT. I got it backwards. My point is, if it's a Y complex, treat it like VTAC, not SVT, right? So I would not use adenosine on a Y complex tachy. Cool. The other thing is, when you push adenosine, you should always see this, where they kind of break for a few minutes. The patient should be uncomfortable. They get this sense of impending doom. I usually whisper in their ear once I push the adenosine, you're going to feel like dirt for a second, right? So they know it's coming, right? If you don't see this, if they don't feel like dirt for a second, adenosine did not get to them. All right. So they should get that break. If it does not work, you got to think, okay, 1, it's not SVT, or 2, more likely, medicine didn't get there fast enough. Did it go up the line? Did I pinch the tubing the wrong direction? Okay. And that dose does not count. Start over. Right. After the adenosine, you should go back into a sinus rhythm. Sometimes I'll go back into SVT. Sometimes you'll give adenosine and you look and you see flutter waves, and it's like, oh, you don't have SVT, you had atrial flutter. Hey, no problem. We can work on that too. And you'll pick that up. So it can be therapeutic or diagnostic. But here's one that had SVT. They got 6 of adenosine, converted nicely. After you slow the rate down, redo a 12 lead, we're looking for ischemia. In a 27-year-old like this patient, probably not the case, but you don't want to miss it. All right. Most SVTs are stable. Think of your vagals, get them on the monitor, get a 12 lead. That 12 lead is important for us because we can look at the cardiologist can look at it and figure out, oh, here's the location of this. We can go in and ablate you and do this medicine. For us, it's just fix the rhythm. But if you get a 12 lead, it makes the downstream effects for the patient a whole lot better. Tips: if it doesn't break, medicine didn't work. Other tips is if they are unstable with the SVT, it's probably not SVT. It's probably atrial tachycardia or something else, AFib. Something's driving that fast rhythm, and they're sicker than you think they are. Okay. My bet is you would probably never have to synchronize cardivert and SVT. If you synchronized cardiovert somebody because they're unstable and they fail adenosine, they were probably an atrial attack and have underlying heart problems, and it wasn't SVT. Okay. Oh, vagal maneuvers. How many cat people we got here? Raise your hands. Any dog people? Okay, I know we have some good people here. There we go. Yeah. Fair enough. That's a mesmerizing video right there. But if it doesn't break, you got to think about something else. Your atrial dysrhythmias or something driving it, such as a PE or something, right? Inappropriate humor. There we go. Thank you. Somebody's now awake. Go. All right. What about this one? Too fast, too slow, or okay? Yeah. What's the first thing you say when you see that, though? Yeah, I usually use profanity, which I'm not going to do here, right? So I'm thinking something really inappropriate, and exactly, right, to my brain, talk to myself. Yeah. So, but my algorithm, too fast, too slow, or okay? I'm going to say 300, 150 is greater than 150, so it's too fast. Is it narrow or wide? I would argue that is wide, right? So I should be done. Is it regular or irregular? I'm going to lay my hands on my patient looking for a pulse, more so if they even have a pulse than anything else. If you get a 12 lead on a dead person, though, that's probably not good either. You should have recognized that before you got your 12 lead. So what is this rhythm? VTAC. Be advised, your machine will sometimes say SVT with aberrancy, AFib with aberrancy. Don't trust the machines. That is a Y complex dysrhythmia, right? That is VTAC until proven otherwise, all right? And proven otherwise is the cardiologist telling us. Otherwise, for you, for me, that's VTAC. So after we've got our 12 lead, we've dropped a few inappropriate words. This patient is sitting on the side of the bed at the house and they're short of breath. What are you going to do for them? Blood pressure is 100 over 60, breathing 24 times a minute and sat 92%. Glucose is 216. Okay, you can cardiovert. I'm good with that. Remember, with cardioversion, you usually got to have your lead zone and your pad zone for those folks. Okay. So, oh man, I had a good joke on this one, but I already blew it. So, the game show is things that make you uncomfortable, right? Is that rhythm? Yeah. That. Just to be politically correct, I had to put a Republican in there too. So that guy should make you uncomfortable, right? The CDC should make us all uncomfortable and probably get censored. And then this movie should make you uncomfortable. Anybody's ever seen that movie before? Yeah, it's a funny movie. You can't watch it now. We've already talked about too fast, too slow. We said this is VTAC. They're short of breath. So stability on these guys is relative. The question you want to ask, do they have a pulse or not, right? So if they have a pulse, they're alive. Our options are medications or synchronized cardioversion. My advice, if you're going to synchronize cardiovert somebody, they should be altered. If the dude's talking to you, saying I can't breathe, my wife's mad at me, I can't watch the game today, I'm probably not going to lighten them up without sedation. Okay. I would probably try medications first. If they're gorked out, confused, looking at you, altered, hey, pads on, sync button, put it at what energy level you're going to use. Yeah, I'm fine with that. Yeah, there's no real science behind that. I'm probably getting in trouble for that phrase too. So 1 to 200. If confused, put it on 200. If that works, great. The next time if it doesn't work, crank it all the way up. Okay, more is better. It's like money, right? More is better. Cool. Amy, I want to go 200. Okay, yeah. Now that's fine. Yes, sir. Yeah. 2 drugs, amio or lidocaine. Some places are just carrying one, some carry both. Either one is reasonable. Amio is a great drug because it works for SVT, AFib, atrial attacks, and VTAC. Lidocaine is just your ventriculars. I would say if they're in, you want to try that first, that's reasonable. And then you can use electricity if it does not work. And thus they're unstable. And I define unstable as altered mental status plus poor perfusion. Yes, sir.
So go back.
Yeah.
What's your thoughts on sequential?
Yeah, so from a practical standpoint, my thought is that's probably not. I would do regular defibrillation or synchronized cardioversion, right? So if they're in VFib, no pulse, and you work them for a few minutes, and you want to do the dual sequential, we got 2 machines. That's up to you and your medical director. I'm not a big fan of it. Yeah, yeah. And some places around here would do it too. We do it some in the ER occasionally. It's just rare. Most of the time, if you secure airway, you give them your first dose epi, you start an antiarrhythmic, and you defibrillate. It doesn't work. Switch pads from high and lateral to anterior posterior and try that. I know years ago there were some issues with just messing up your machine doing that as well. But I don't use a lot of dual sequential stuff. And for synchronized cardioversion, there's no way I would do that. There's no way to sync because you couldn't get two machines to sync it up. But for VFib, if your med director's cool with it and you've done the basics already, that's a reasonable approach. Yeah. The other thing I would try before I did that, if I had somebody that was in VFib and I've given my amio or my lidocaine, I've shocked them, I've got an airway, I've given my epi, I'd probably give a big slug of mag first to see if there was a QT issue, right? And I'd probably give a dose of calcium as well in case there was some hyperclay before I went to getting two machines, just because that's just complicated to do. So we talked about synchronized cardioversion. We got time for a couple of STEMI cases. Female, weak and nausea. Remember, acute coronary syndrome is not always chest pain. Sometimes it's nausea. Sometimes it's shortness of breath. Sometimes it's weakness. In an older person, sometimes it's I don't feel good, right? Get a 12 lead. There's no risk, all right? You're not going to get them radiation poisoning. You're not going to hurt them. Get the 12 lead. The only risk of doing a 12 lead is now you got to look at it and figure out what to do with it, right? So it's a 12 lead. Again, you've probably already seen it, but my mind is too fast, too slow, or okay. I look injury patterns, 1 AVL 5 and 6, 2, 3 and AVF, V1 through V4, AVR. I look at my intervals at lead 2. My QRS is narrow, so I don't have to go to V1. So it is a sinus rhythm rate of about 70 to 80. It is 0945. Is it STEMI or no STEMI? Yeah, say it. Yeah, say it. Say my name. It's a STEMI, right? Yeah. That was inappropriate. What now? Yeah, it's a STEMI. Yeah. So it's a STEMI. Yeah. So obviously it's a STEMI, right? So what are you going to do for this patient? What are your priorities of care for this lady? Yeah, yeah. Send me a helicopter. Yeah, right. Yeah. Yeah, not today. That's right. Yeah, send me a boat today. So obviously there are a lot of mnemonics out there. There's the Mona, the Phona. There's one that I started using a couple of years ago that's kind of in sarcasm, but it makes sense too. But basically, first drug we want to give this person is what? Aspirin, right? So we're going to take that clot, and the goal is to make the platelets not adhere so the clot doesn't get bigger. It doesn't fix the problem, but it potentially can slow the process of that STEMI getting bigger, right? So they're going to get an aspirin. I give these folks pre-oxygenation, whether they're hypoxic or not. Some folks don't like that. That's fine. You won't offend me if you don't go that route. The big risk of death in the first couple of hours of a STEMI is VTAC, defib arrest, or cardiogenic shock. And if they have either one of those and you're in the back of a truck by yourself and you don't have O2 on, you've kind of hosed yourself and the patient. So I throw O2 on them. If you don't like that, throw your nasal cannula on them and don't plug it in. All right, plug it in, but don't turn it on. But you got it in case you need it, right? Oxygen, we talked about. Nitrates for chest pain causes vasodilatation. If they're hypertensive or normal tensive and having chest pain and you can't fix them with your aspirin, your O2 and reassurance, nitro is reasonable. Inferior infarcts, sometimes you'll get preload reduction. They get hypotensive, so make sure you have IV access and fluids going. If they're bradycardic, rates less than 60 or 70, no nitro. If they're hypotensive, no nitro, okay? If they're taking certain medications, so if you pick them up at the Motel 3 at 2 o'clock in the morning, right, they don't get nitro either. The mnemonic that I started using out of sarcasm is SITAIVNRTLPOM. Pretty easy to remember. You can get a tattoo in your arm if you want to use that one. We have shirts too if you want those, but it's suspect, identify, treat. They get an aspirin, they get IV access before nitro, they get RTLP, which is ride the lightning pads. Remember, folks in STEMIs, they have VTAC, VFib arrest. So if you don't have your pads on them and you're back of the truck with them and they start shaking and they go into VFib, now you got to stop, pull over, get help, do things. If your pads are on them, you can just put your cigarette out, charge at 200 or 120, whatever, and shock them, right? Oxygen and then morphine for pain control. Morphine also lowers the blood pressure and it takes them from having chest pain to feel like I'm scared to now I got chest pain. I don't really care. I'm high. So suspect, identify, treat is a big thing. Remember, the cause of death in the first couple of hours is VTAC, VFib arrest. If you got your pads on, you can just synchronize, excuse me, you can just shock them, getting them back. Works pretty good. That's for Dr. Willett. All right, we got good. Just look at this one. How would you write this one up? Too fast, too slow, or okay? And then I would look injury patterns. I'll let y'all look at those. And then you can say the rate is in the 90s. It's the sinus rhythm. It's 950. Is it STEMI or no STEMI? Yeah, I'll call it a STEMI too. Yeah, it makes me uncomfortable. So I'm looking at 1, AVL, and 5 and 6. I got T-wave inversion, right? ST depression. So I know there's something going on somewhere. I look 2, 3, and AVF. It's reasonable. V1 through V4 make me uncomfortable. V1's got some elevation, but when I go to AVR, I'm up in AVR and I'm down laterally. In my mind, this is going to be a left main coronary STEMI until proven otherwise. And I get it. It doesn't say STEMI. So when you call TCC, they're going to say, does the machine read STEMI? And you're going to have to say, no, it doesn't. I'd like you to send this to the cath lab hospital that I pick, and you can pick it. Hey, who's green for cath lab? You know, A, B, or C. You pick C. Hey, send this to hospital C, that the doc look at it, and they'll say yes or no to put it in the STEMI system. If they say yes, you go to that hospital. Cath lab's waiting on you. If the doc says, nope, not a STEMI, you go to that same hospital where that doc saw that EKG, and he makes that decision there. You still go to a cath lab hospital because that's a STEMI for us until proven otherwise, even though the machine doesn't say it. TCC will enter that into the system for you if that doc approves it. If he doesn't approve it, that's fine. You made the attempt. You still go to that same hospital. What you don't want to do is you look at this and you got this 60-year-old female with chest pain that looks like crap. You got an abnormal EKG. The cath lab center says, no, not a STEMI, don't put it in the system. And then you stop at a small community hospital that does not have a cath lab because you just hose that patient. Does that make sense? Cool.
Hey, Doc.
Yes, sir.
So if you don't mind, go back to that last folio.
Yes, sir.
I think this is a good example, and we had some people that wanted some elaboration on this.
Yeah.
So if we look at this one in V1, especially in V2, we see what looks like a wide QRS.
Yes.
But it's not a bundle branch block because the QRS in limb lead 2 is normal. Is that a true statement?
I would say it's true-ish. Yes.
True-ish.
Yeah. Yes.
Okay. That's kind of how my feeling is too.
Yep.
So this, I think, is where a lot of people get confused on when to apply scarbosa and when to say it's a bundle branch. When it's wide in some places and it's not wide in lead 2.
Right. So, but it's not wide in lead 2. So by the rule that we've been doing, we would not go to V1 to look for a left bundle. If in your mind you looked at it and you said, oh, it still looks like a left bundle, I would argue that up in AVR, down anywhere else is still enough to get somebody in.
Got you.
Okay. So there's not really scarbosa, but we still have our AVR rule.
So if it was not up in AVR, would you call this a STEMI?
I would not. If it was not up in AVR, I would not.
Yeah, because the elevation in there's elevation in V1, right?
Correct.
But we don't have elevation in 2
Correct.
contiguous leads.
Yes. Yeah.
Okay.
Now I can still be concerned about this EKG in this patient, and I can still send it in. And I'm still, when I get to the hospital, hey doc, this is my EKG, this is my story, but I would not call it a STEMI if that was not up in AVR.
Got it.
Does that make sense? Remember, our EKGs are a screening tool, right? So I could say a STEMI, Carl could say, nope, not a STEMI, but yeah, I'm gonna cath him anyway because I'm not sure what's going on. Or they could say, nope, not a STEMI, I'm not gonna cath him. I'm like, that's on you, roll tide, right? We're just screening these patients for badness, things that kill people. This one, too fast, too slow, or okay? And do you say STEMI or no STEMI? I'd say it's got some artifact. I would probably repeat this unless the patient was flopping and grumpy and I couldn't repeat it easily. I got enough data that I could say leads 1, AVL 5 and 6 look reasonable-ish. 2, 3, and AVF look reasonable-ish. V1 through V4, I got some T-wave inversion, makes you think posterior. AVR looks okay-ish. I go to lead 2, it's kind of crooked, right? But QRS looks a little wide. So I'm gonna go over to V1. I got pointed up, so it's a right bundle. So I know that that V1 through V4 stuff is normal in a right bundle. Okay. So STEMI or no STEMI? I'd say no STEMI. If I was concerned about the patient, call that cath lab hospital, send it in, let the doc look at it. All right. If you're concerned about the patient, they still get the aspirin, the pre-oxygenation, they get them the pads if you're concerned, they get the appropriate therapy, and they go to the cath lab hospital. But I would say not a STEMI based upon that EKG. Yeah. Yeah. What about this one? Too fast, too slow, or okay? Yeah, rate's okay. Now look at injury patterns. Now, to be honest with you, my mind, my eyes are automatically going to that death grip in 2-3 and AVF, right? So it's hard for me to go back and look. So I got to force myself to look at 1, AVL 5 and 6. AVL's T-wave inversion, ST depression should make me think there's a STEMI somewhere hanging out, probably inferiorly. I look at 2-3 and AVF. Oh, I found it. V1 through V4. Yeah, V1 and V2 are concerning, but who cares? Because 2-3 and AVF are bad, right? I go back and lead 2. QRS complex is narrow. Peer interval's fine. Don't care about a bundle. So this is an inferior STEMI. Does that make sense? So we've kind of talked about what you do. What we do in the hospital was we'll throw an ultrasound on the heart. We're looking for wall motion abnormalities. Is there something really going on there? We're probably going to see it with that patient. You give them aspirin. We're going to give them other medicines such as heparin, which is a blood thinner. And then we'll give them a second antiplatelet such as Plavix, Brilinta. Some places use other drugs, and that just makes those platelets less sticky so this doesn't get bigger. The clot doesn't get bigger, okay? If we're at a hospital that doesn't have a cath lab available right now, and it's going to be more than 30 minutes after you get there, or more than 90 minutes from the scene, we'll give them a thrombolytic like we used to a lot, or like we do for strokes, that kind of breaks open that clot, and they go to the cath lab later with cardiology. TNK, tenecteplase, is the main one. Some places are still doing TPA, but either one is fine. Other states, there's a drug out there called Retivase. I haven't looked at it in the past couple of years, but Retivase is a drug that's pretty easy for pre-hospital use. So you got a patient having a STEMI and you're out practicing in the middle of nowhere, right? All right. You screen your patient. Are you at risk? I mean, do you think it's a STEMI? Yes or no? And then do you have any absolute contraindications to thrombolytic therapy? So anytime you had an aneurysm in your brain or hemorrhagic stroke, any recent ischemic stroke in the past 3 months, any recent spinal surgery, any active GI bleed, and if all those are negative and you're more than 90 minutes from a cath center, you give that first dose of Retivase in the field. All right. And then what you do is you start moving to the hospital and you repeat your EKGs. If their pain gets better and their EKG normalizes, they go see the cardiologist, they get a cath lab later that night. Okay. If the pain does not get better, EKG does not normalize, they get the second dose of Retivase at the hospital and go to the cath lab. I don't think anybody in this area is doing that right now, but that is a potential things that we could do. I would advise if you're going to do that, that obviously the state's got to approve it, right? There's got to be a waiver. There's got to be fantastic training in QI. You got to make sure that any cardiovascular group that you're taking a patient to at a hospital is in agreement with that as well, because you don't want to delay cath lab time. But for some locations, it's a reasonable thought. Retivase, yeah. Yeah, that's crazy. I didn't know that. Cool. Cath report. So right coronary. Where's the first one? Got them backwards. All right. So cath report, big stenosis, much better. So that's what you need to do, right? Restore that blood supply to the heart. Heart gets better. Pain goes away. Folks do well. This one, too fast, too slow, or okay. I say it's still less than 150. Injury patterns. It is now 9:54. I got about a minute. So STEMI or no STEMI? That's a tough one, isn't it? Yeah. So inferior makes me a little bit uncomfortable. I also have some problems in V3 and V5. So I would say that this is enough that I'm going to say, yeah, that's probably a STEMI, an anterior. I got some changes in AVL that are reciprocal maybe. So I'm going to call this a STEMI. And if I'm wrong, roll tide. But that's a STEMI until somebody proves me otherwise. That one, again, that one makes my eyes kind of jump to 5 and 6, right? I would advise that even if your eyes go to the big stimmies, that you go back and read the rest of your rhythm, look at your intervals so you don't miss something. Remember, this is a screening tool. The EKG screens for badness, right? And a STEMI is bad. Running out of time. I won't do that one. What else I got? STEMI or no STEMI? Yeah, I don't say either. No STEMI. Yeah, right. Cool. If your patient was 80, chest pain, diaphoresis, history of diabetes, hypertension, had multiple stents in the past, the story makes you uncomfortable. EKG is normal. What do you do with the next EKG? Well, I just gave it away. What do you do? Run another one. Yeah, repeat those. Something. That's right. Yeah, check for changes, right? Yep, changes everything. I'm not sure what that picture was for. I had a joke, but I've already forgot it. That's it. It probably was. Yeah, good one. Yeah, yeah. That makes me uncomfortable. You thinking that way, sir? All right. On that note, we'll stop. So, questions, comments, statements. Yes, Chief.
Yeah, so we got a couple of things online that asked a while ago, so got to back up. So one, we had somebody post a comment, Narcan as well for prolonged QT. Does Narcan help prolonged QT?
Not my knowledge, no.
Yeah, me either.
Yeah.
I went ahead and posted that, but
Yeah.
yeah.
And again, my thoughts on Narcan is for respiratory arrest. Okay, don't give it to the confused patient who's acting weird. Who cares? You may remove that opioid. Now they're weird and combative. So don't put yourself in that situation. If they're not breathing, ventilate them, oxygenate them, Narcan them. If they're not breathing and you can't ventilate and oxygen, Narcan the crap out of them. Otherwise, don't give them Narcan.
Yep. And then the other one was, can you elaborate on giving calcium in those times? I think we were probably talking about Brady dysrhythmias.
Yeah. So,
and do we need to call for that, and what dose?
Yeah. So if you think someone has hyperkalemia and EKG changes, my understanding is calcium is category A. The dose is 1 gram calcium chloride or gluconate. So if I have somebody that has a gimme, hey, I missed dialysis last week. They got a big graft in their arm. The heart rate is now 30. Looks like a junctional rhythm. They're talking to you. That's hyperkalemia. If their heart rate is 30 and they have heart problems, they should be hypotensive and cardiogenic shock, right? So that's a no-brainer. That's probably hyperkalemia. They get calcium 1 gram. You can also give them albuterol. That should be easy to do. And for hyperkalemia that is symptomatic, I would argue that's category A.
Yeah, and the albuterol wouldn't have anything to do with bronchodilation.
No.
It's to help to move the cellular
Yes,
potassium, right?
So the calcium stabilizes that cell membrane. The albuterol shifts it to make it better. And you'll actually see that EKG change in front of you if you give enough albuterol. So
very good.
In cardiac arrest in Alabama, I would argue that hyperkalemia could have been the cause of it. So I give a lot of calcium. There's no risk and potential benefit. Again, talk to your medical director and make sure everybody's good with that. Yep.
Narcan first, of course. 'Cause
Yeah.
It's epi first.
Yeah.
An early Narcan.
Yeah. Yeah. So my thought on cardiac arrest, I don't give Narcan in cardiac arrest because if they're in cardiac arrest from an opioid overdose, it's because they had respiratory depression and dropped their blood pressure. I should fix that with my airway management as an ALS provider. I should fix their blood pressure with a dose of epi. So I'm not doing a lot of Narcan in cardiac arrest. Right?
So in other words, Narcan doesn't have any cardiac effects.
There's some studies that it may, but I think I don't think it's prudent, to be honest with you. I think the biggest bang for your buck is aggressive airway management, lethal dysrhythmia recognition and treatment, and then epi. Now, if you've gone through that and you've given your epi and your calcium and they're still dead, dying, and you give Narcan, is it going to hurt them? No. But I'm not a big fan of that. The other use for Narcan that's kind of going off topic, it would be if I had somebody that had a clonidine overdose, Narcan sometimes works for that, but it doesn't work as good as a milligram of epi through the IV and an ET tube, right? Yeah. Yeah. Yeah, again, I think the mainstay of therapy for that person is going to be airway management. And if they're hypotensive, push dose epi, fluids, or an epi infusion, right? You just get complicated thoughts with that. It's just Narcan is not the save all that people think it is. It has its place. It has a great place in the non-medically trained people that can't manage airways and give epi. But for us, I think we need to stick back to the basics of airway management and then, vascular support with epi. We good, Chief?
We are. Are you
All
ready
right.
to take a break?
Yes, take a break.
Yeah, let's take about 5 or 6 minutes, everybody. If you're online, please remember to fill out an attendance form. The link is in the chat box. The password for the attendance form today is the word Winston with a lowercase w. It is case sensitive. Sorry for the background noise. I'm not sure that it's what? It's Wednesday. Oh, it's the tornado siren test. Okay. Yep. And we'll be back in about 5 or 6 minutes with Dr. Adams on a lecture on respiratory distress. Hey, everybody, welcome back. We're going to get started back with Dr. Adams is going to give us a respiratory emergency lecture. So welcome, Dr. Adams, and take it away.
All right, thanks everyone for being here. So my lecture is pretty interactive, so I'm going to ask y'all some questions. I appreciate y'all just attempting to answer. It's a safe space. There are no wrong answers. We can kind of go over, well, I guess there are wrong answers, but we can kind of go over what the preferred answer would be. I'm going to talk about respiratory emergencies. Some of these are respiratory lookalikes, and so it's going to be a case-based presentation. So we'll just kind of go through some cases, a little bit of an introduction, some bread and butter cases that you've probably seen not infrequently, and then some zebras that you may encounter that you really want to know how to manage if you do. So respiratory emergencies account for 7.8% of EMS calls. So this is something that I'm sure y'all see all the time. And whenever you do see it, you're going to want to know how to manage it. Oftentimes, people have chronic respiratory disease, especially here in Alabama. We got, heavy smoking population. And so we have a lot of patients with like COPD, lots of kids with asthma. And so it's important to know how to manage these patients. So we'll go ahead and start right off with a case. So this case number 1 is going to be about an 8-year-old female. She does have a history of eczema, but no other diagnosed medical problems. Her parents called for her saying that she felt like her chest was really tight and she couldn't breathe. You get her in the truck, her vital signs, heart rate of 145, her blood pressure is 98/56, respiratory rate's 41, her oxygen saturation is 91%, temperature is 99.6. You do a quick physical exam, you're listening to her diminished air movement in all lung fields, and she's working really hard to breathe. So what else do you want to know about this patient? She has some cream for her eczema, that's it. No allergies. So actually her sibling's been a little bit under the weather. Mom says that they have rhinovirus for what the pediatrician told them. Y'all have any idea what is going on with her? So this is silent chest. And so a lot of these kids, I've actually seen this a couple of times, will come in with a really severe asthma exacerbation as their initial presentation for asthma. You're not hearing wheezing when you're listening to them. That's because they're not moving air. And so they get there, they're really sick, and nobody's really thought about asthma. They haven't gotten any medications. This is bad. So these kids hit the door pretty sick, and we really have to work quickly to turn them around.
Hey, quick question, Dr. Adams.
Sure.
So would you still see the shark finning on capnography even if you couldn't hear the wheezing?
Yes.
Oh.
You would. Yeah. We'll touch a little bit on that also here in just a second. First, we'll look at the pathophysiology. So in asthmatic airways, their airways are a little bit more inflamed at baseline, but as they have an asthma exacerbation, they're going to have tightening of the smooth muscles around their airways. They also get increased mucus production. So really just a huge obstructive process, trapping air behind their bronchioles into the alveoli, so they can't get the air out. They're not moving air in or out, but usually they're trapping the air in when it's in. And so that's really what you're seeing in these patients. There's a lot of triggers for this. I'm sure y'all have seen a lot of this in the winter season when kids are picking up, rhinovirus is a pretty common trigger. Also, when they're around allergens, like you pointed out, anybody who has allergies and asthma, certain allergens may trigger them to have an asthma exacerbation. Sometimes cold can do it. Different chemicals or perfumes can trigger some people, and sometimes even exercise can trigger patients to have an asthma exacerbation. So I think big things, obviously, we're going to get IV access. Sure. So yes. So that was actually, let's see, we'll get to that here in just a second. Like Chief Wade had mentioned, what we have on capnography with obstructive processes is you're going to have this like shark fin appearance to the capnography, and that's just from the obstruction. So if you're confused and you're thinking, I'm not really sure, this kid doesn't have a history of asthma, I'm not really sure what's going on, I'm not hearing wheezing, you can hook them up to capnography and actually look for this to indicate an obstructive process. So this is a good way to try to help you get some more information about what's going on. Obviously albuterol. So we want to get them hooked up with some breathe-in treatments, specifically in this population. So when we're giving albuterol, that is for patients who we think need the bronchodilation from it, not just because they have increased work of breathing, because sometimes that can actually make things worse. And so what we want to do is we want to look for very specific indications for it, like COPD or asthma, when we want to kind of open up the airways a little bit more. Any other meds that y'all can think of that y'all would want to give this patient? Yeah, so this patient in particular probably wouldn't benefit as much from rack epi. They could benefit from it in this like more severe case. If it was a patient who was having like a milder asthma exacerbation, I wouldn't reach immediately for rack epi. You can give it if it's someone who's having like silent chest, very severe work of breathing. Another thing you can consider, MAG. So MAG is actually a bronchodilator. It will dilate using some smooth muscle relaxation. So you can give magnesium through the IV to try to help out these patients. Obviously, steroids should try to reduce some of that inflammation that they have. That's not going to work immediately, but it's good to get it on board as soon as possible, because that way, you're ahead of it. If you have like a 30-minute transport, you've just kind of put them ahead 30 minutes. Usually in kids, we do like a 2 mg per kg dose. In young kids, we would kind of stop at 60 milligrams. Adults, you're probably just going to give the 125 up front. And that's usually how we dose that. And then kind of circling back to epi, this patient in particular, I've seen this done more recently. It's been more common, people giving IM epi for these reactive airways diseases in the field, just to get some more beta agonism kind of behind the treatment, as they're already doing these other options as well. I wouldn't do it as an isolated option. Obviously, make sure you're doing albuterol. That's the biggest thing that they're going to need. But you could do IM epi and even rack epi if you are thinking that they're sick enough.
Hey, Dr. Adams, we got some folks commenting to me that, yeah, if they're not moving air enough for you to hear, they're probably not moving air enough to get the albuterol where it needs to go. And we had some folks already suggesting starting off with epi 1 to 1,000 to facilitate the inhaled drugs and get it turned around. So would you agree kind of with that statement?
100%. So if they're not moving air, that's why, I kind of put IM epi up here. If they're not moving air at all and albuterol is not helping, I would probably go the IM route. You can consider rack epi, but if your albuterol is not working, the rack epi is probably not going to be circulating as well either.
I know there's a lot of confusion sometimes too in the pre-hospital setting. Hey, I've got this kid. We see the shark finning. We're not hearing breath sounds. We're assuming this is kind of status asthmaticus, even if it might not meet that definition, but based on what we're seeing. So we're indicated for epi, but I've already got an IV. So could I give 1 to 10,000 IV? I know that has happened in the past. Any discussion on why that's not a great idea or why it would be okay?
So I think that's a good question. Given IV epi is going to have more side effects, you're going to be given a lot lower doses. I think you could potentially do it if you have IV access at really low doses. So when you're dosing epi, you have to make the microdose form. Obviously, you're not going to take the 1 to 1,000 form and immediately give it IV to this kid. What you're going to do is you're going to make microdose epi, which I actually have a slide on that a little bit later on. We can kind of talk about how that's made if y'all don't already know. And you can do that yourself using what you have in the rig. And so what you'll do is you want to target the dosing based off of which receptors you want to hit. So if you have somebody who's hypotensive and you're trying to target the epi for more of like a pressor, you're going to actually give higher doses. But if you want the beta agonism, you actually want lower doses. So you would give like tiny doses, like less than 10 micrograms in an adult. So in this patient, you'd probably be giving like 5 micrograms to try to help with that.
Yeah, I think you could speak to as well. There's also an issue of how long the drug stays in the therapeutic index, because it just stays longer. IM is my understanding. IV, it gets in faster, but it's also all faster. Is that right?
Yes, and so
Gives you a longer period of time to kind of break the exasperation.
correct. And so if you're not going to want to be sitting there redosing the microdose epi over and over again, so that like 5 microgram dose is typically like, you would probably give in like 1 to 2 micrograms per minute to try to keep it in the system. So if you want to keep it in their system, you just go for the IM form and just kind of leave it at that. And then you only have to dose it one time. And by the time you're at where you need to be, they can kind of take it from there. And so this is kind of circling back to what you had mentioned. And so this is after you've given some meds, you had a pretty long transport time. The patient's gotten all the meds that we kind of just talked about. And now we have this physical exam. She's got biphasic wheezing, so she's wheezing pretty good with inspiration and expiration. But you're actually hearing the air move in all of the lung fields. But she still has this like prolonged expiratory phase, so still trapping some air behind those bronchioles. And why is that? Yeah, so she's actually moving air now. I have heard when I've had patients dropped off to me before, people are more concerned when they start to hear wheezing. And that's actually a good sign. If you weren't hearing wheezing initially, that means you've started to open up their lungs. They're actually moving air, which is great. So this is actually what you want. You want to be hearing some wheezing after you've started your interventions.
Dr. Adams, would mag sulfate play a role in this case?
Absolutely. So I would definitely give MAG just as a bronchodilator to act on the smooth muscle. Some people like it more than others. It can cause hypotension if you give it too quickly. So this is not something you're just going to like slam in. You're going to give it over like 20 to 30 minutes. So you're just going to kind of hang that at the dosing 50 milligrams per kilogram up to 2 grams as your max dose. And so you're just going to kind of hang that there and let it be running for about 30 minutes. Yeah. Okay, so moving on to another case. So here we have a 46-year-old female. She's otherwise healthy, but all of a sudden had chest pain that's worse with inspiration and difficulty breathing. Her vital signs: heart rate is 135, blood pressure is 89/50. She's breathing about 31 times a minute. Her oxygen saturation is 82%, and her temperature is 99.9. You do a quick exam of her. You notice that her work of breathing is really significant. She's kind of holding her chest, but you're listening to her lungs. You're not hearing any abnormal lung sounds. So she's moving air, and her lungs sound clear. So we're going to get an EKG, and I want you to kind of help me out interpreting this. So this is her EKG. Since she had chest pain, we immediately kind of got that after getting IV access and getting her on some oxygen and on the monitor. So anybody want to kind of throw out some things that they're seeing with this EKG?
Quad QRS.
Mm-hmm. Yeah. So she's got a right bundle. If we look at it, we can kind of see we do our rule like Dr. Ferguson was just talking about, go to lead 2, a little bit wide. We go over to V1, we see we have a right bundle branch block. Also, if we're looking at our axis, we can look at like lead 1 and AVF. We see that we have pretty extreme right axis deviation. We also have some T-wave inversions in V1 through V4. So all of these things are some of the things that we're seeing. And anybody know what this kind of points to whenever you see these findings in like combination on an EKG? This, in general, is right heart strain. And so I think I heard somebody say S1Q3T3. So that's also on here. So if you look in lead 1, we have an S wave. In lead 3, we have a Q wave and an inverted T wave. And so that is also a very common pattern with PE, or is associated with PE. But what it really means is right heart strain. So other things can cause right heart strain, pulmonary hypertension. Some people have S1Q3T3 on their EKG all the time. But this is something, if this patient's otherwise healthy and then all of a sudden has this EKG, you may not have a baseline. You don't have a reason to think that this patient would have these EKG findings, obviously at baseline. So this indicates right heart strain, and you should definitely be concerned if you weren't already with the vital signs. And so now you have this EKG. What else do you want to know? She's still able to talk to you. She can answer some questions. Yeah, so she just got back from Europe. Yeah, so she says she just got put on a new birth control. She doesn't really know what it is, but she did just start a new birth control pill and she does smoke. Yeah, so most likely diagnosis, y'all kind of already called it before we even got here, a PE. And I would call this a massive PE because she has signs of hemodynamic instability. So this is bad. This patient is sick. And circling a little bit back to the S1Q3T3, things with PE that is common that people, see that on EKG and they immediately jump to PE, and that's okay. But if you didn't have that on the EKG, that does not mean the patient does not have a PE. So most commonly, you're actually just going to see things like sinus tachycardia, just nonspecific changes in the T waves and ST segment. You're not always going to have like an S1Q3T3 pattern, even with massive PEs. But if you do have it, that's a sign of poor prognosis. And so the signs that are indicating right heart strain are also indicating that this patient could do poorly and have a high mortality risk. And so also badness when you see that. So yeah. So pathophysiology, the Virchow's triad. So y'all kind of named like the trifecta. So she had stasis, she's been on a plane, been sedentary for a long period of time. She also could be hypercoagulable. She said she's on this birth control. She doesn't really know what it is. Maybe it contains progesterone, and maybe she is hypercoagulable from that. If we would have asked about her family history, she has clotting history in her family. And so all of that kind of is giving her higher risk for PE. And then she's also a smoker. So we just kind of have the trifecta here that's putting her at really high risk. So how this works, you get the clot in the leg, and then the clot will move obviously up through the inferior vena cava into the heart and then out into the lungs. If the clot is non-obstructive, they may have less damage to the lungs, but you can get these obstructive pulmonary embolisms that can cause infarcts behind them because that area of the lung is no longer getting any blood flow. And so typically when they get to the ER, we're going to get a CTA chest. And this is what we would see on our patient. She has a saddle PE. So right in our, there's our main pulmonary artery kind of branching off into the left and right. We have that saddle PE there. And normally we would have some, lighting up in the lung field of the blood vessels. We're not seeing a whole lot of anything. And so pretty obstructive process going on. And so she's obviously really sick. Another thing that we typically do, we can quickly look with ultrasound. I know ultrasound starting to come a little bit more into the EMS world. So if you were using ultrasound, you could look at some of the cardiac windows. This is the parasternal short axis view. What you see here is the left ventricle is that circle. And it kind of looks like a D, and it's not supposed to. So normally the left ventricle is always circular, but when the right heart gets so much pressure in it that it starts pushing into the left ventricle, and that happens with this obstructive shock, and we call that D sign. And then if you look at, like an apical four-chamber view, here we're just seeing the two ventricles, but you can see that the right heart is much bigger than the left heart, and that's supposed to be the opposite. And so all of this is pointing to, massive pulmonary embolism. So what do you want to give her? What are you going to do? She's hypotensive. She looks bad. Let's say you got 30 minutes so you can be at the hospital. What do you want to do? Yes, definitely. Yeah, maybe that. So you consider fluids. So she is hypotensive, and she has obstructive shock. And so something we can think about doing is giving her some fluids and just see how she responds. If she doesn't respond to fluids, is there anything else you can think of that you can do? We'll say that these are her repeat vital signs after her fluids. So her blood pressure is still 89/51, still tacky. Her SAT's a little bit better. She'll breathe in a little bit fast, but we're still worried about that blood pressure. Maybe some epi. So microdose epi, I don't know if y'all are familiar with how you actually can make this. I would give her like 20 to 30 micrograms. You can redose it every minute, but I would usually give it like a couple minutes to try to work. And what you can do for this, the reason you wouldn't do more fluids is something called the pulmonary embolism death spiral. It is scary as it sounds. So if you continue to give fluids, the right heart is already under strain, and it can't push things forward. So if you continue to give fluids, you're going to start to get pressure and more pressure into the left ventricle. We already saw the D sign. The right heart's just going to continue to push on the left ventricle, and you can get decreased left ventricle filling and further issues with cardiac output. And so as you go, if you just keep giving more fluid, you're going to keep this like vicious cycle, which is going to ultimately cause her to code. And so that's not what we want. And so I would, start with fluids, maybe like a liter max, and then I would kind of reach for something else, so just to try to temporize the blood pressure until you can get to the hospital where she can get more definitive management. And so making microdose epi, does anybody know how you make it? Like you probably do. Anybody? So what you're going to do, I know right now.
So this is kind of dependent on how you get your drugs packaged,
Mhm.
right? So hopefully people are getting epi 1 to 10,000,
Mhm.
and we can use that. So it's just a single dilution.
Yep.
A lot of agencies are getting only 1 to 1,000, but they're doing a single dilution to get to 1 to 10,000.
Yep.
And then a double dilution to get to 1 to 100,000. But we heard
Yep.
from Emily Green, our clinical pharmacist, actually at the last EMS challenge, to get away from the 1 to 100,000 terminology. And I already forgot what you said that we're supposed to say. And Dr. Ferguson.
So like probably.
Yeah, we're supposed to be more precise. It's really not 1 to 100,000 isn't a great way to say it.
Yeah.
But I think everybody understands what that means in the
Mhm.
EMS world. So.
Yes. Yeah. So our pharmacists have kind of made us start using the term microdose. They don't like push dose. And so Emily Green is actually somebody who I think kind of wanted us to say microdose, but same thing. And so like we were just saying, it is going to depend on what formulation that you have. I do know that the 1 to 10,000 is on short supply. And so what you're going to do, if you have your 1 to 1,000, you're going to take 9 milliliters of saline, whether that be you push like 1 cc out of a 10 cc flush. You're going to pull up 1 milliliter into that 9 cc's, kind of mix it up, and that will give you kind of the first step here. And then you're going to take that flush that you just made into like a microdose epi, take 1 cc of it into 9 more cc's and dilute it again. If you're lucky enough to have the 1 to 10,000 formulation, you only have to do this once. You don't have to do the second dilution, but at the end you should have 10 micrograms per milliliter. And so then you can easily dose the 20 or 30, but you can just give 2 to 3 cc's and just see how they do. So mortality and PTEs, if the patient is hemodynamically stable, they tend to do pretty well. Mortality is less than 5%. So our patient is hemodynamically unstable, and so these patients typically do pretty poorly. More than half the time they have, they die from this. And so that mortality typically happens in the first hour of their symptoms, and so happens with EMS. And so this is why it's so important for y'all to know how to care for these patients, and so that they can, walk out of the hospital alive. If you're having to transport one of these patients, typically they're going to be on a heparin drip. Heparin works as an anticoagulant. It works on anti-10A. And so what that means is it's going to prevent the clot from growing. It doesn't actually break up the clot. That's a common misconception. What it does is stops the clot from expanding so that your own intrinsic, like fibrinolysis system, can actually break down the clot yourself. And so they're probably going to be on heparin drip after they receive a heparin bolus at the hospital that they were at. And usually that's a flat rate drip for transport at 18 units per kg per hour. So going on to another case, we have a 67-year-old male, has a history of hypertension, calling in for shortness of breath, got a pretty productive cough, and says that he had the flu a week ago. Heart rate's 123, blood pressure 89/47, respiratory rate is 26. He's a little hypoxic with a sat of 89%, and he's febrile. You start listening to him, you hear some crackles on the right side in the lower lobe. What do you think is the most likely diagnosis? So he's also flagging for sepsis criteria if you were looking at his vital signs, but definitely sounds like pneumonia. So this is definitely a bread and butter case. So pneumonia, typically these patients start to get inflammation in their alveoli. They start having more leaky capillaries in that area due to that inflammation. They start having increased mucus production, and so they develop pneumonia. Specifically in patients who are post-flu, they'll get like a lobar pneumonia. Oftentimes, classically, it's like a staph pneumonia, but that is just a clue that they could potentially have pneumonia causing their sepsis. And what do you want to give him? Yeah, so fluid bolus. Obviously, y'all don't carry broad spectrum antibiotics, but with sepsis, y'all can start the fluids in pre-hospital, and we can kind of finish what we're supposed to, the amount that we're supposed to give once they get there. Fluids are super important because this is going to be what we call a distributive shock, and so really important to get fluids on board, and then we would administer the broad spectrum antibiotics when he gets there. So there's his chest x-ray. Got that lobar pneumonia on the right side that y'all were hearing when you were listening. And then we have air bronchograms. You can kind of see the air bronchogram with the black arrows over here. It just shows that the consolidation is there. You can see the actual bronchioles within the consolidation suggesting pneumonia. Herceptin. Yeah. So typically, I think you could potentially hold off to get to the hospital for antibiotics. If the patient's super sick and you want to give, like a cephalosporin up front, I think that's okay. Specifically for pneumonia, usually we would do ceftriaxone and azithro. So if you have ceftriaxone, that is helpful. But we may have to broaden them out, but that's okay. If you're really worried about them and they're really sick, the faster you get on the cephalosporin, the better. And so that can actually improve their outcome. But if you think that they can wait, I would wait, just because we may have to expand into broader antibiotics when they get there. Okay, moving on to another kid. So 3-year-old, has a history of something called laryngomalacia, has a barky cough and difficulty breathing. Parents are worried about him. So they called. Heart rate's 132, blood pressure's 92/63, respiratory rate's 41, O2 sat's 94%, and his temperature is 100.1. You're listening to him. He's got this high-pitched noise when he's inspiring and he's at rest. He's also using his accessory muscles to breathe, and he's tachypnic. So what do you think about this kid? What do you think's going on? He's got the croup. And so croup is inflammation of the larynx. And so you get this swelling of the, vocal cords and surrounding structures. Kids with laryngomalacia just have floppier airways, and so they're going to get this pretty often, and they can get a lot sicker than kids who have normal airways. At baseline, kids are going to have floppier airways anyways, and typically they kind of grow out of this, but these kids have like a actual like pathology of floppier airways, and so they're just more at risk. And so when you get to the hospital, if plain films are obtained, you can actually see something called the steeple sign. And so that is just the narrowing of the airway there that you can visualize on x-ray. You can actually determine how severely ill a kid is based off of their stridor is usually how I do it. Usually you can pretty much look at the kid and say sick or not sick. That the kids who are going to do well are the ones who are not having stridor when they're sitting there. They're not really working very hard. May get a little bit of stridor when they get worked up, but they're, otherwise okay. The kids who are going to be kind of in the moderate severity are the ones who do still have stridor at rest, but they are, they're not like in distress. The ones who are severe, the ones who are going to be trying to position themselves, they're kind of tripoding, they can't talk, they can't eat, like they couldn't, do a bottle at all because they are having such respiratory distress that they can't do that. And so these are the kids that you're going to be really worried about, the ones who fall in the moderate and severe category, specifically the severe category for decompensation. So what do you want to give this kid? So rack epi, I know y'all probably don't carry dexamethasone. I know that y'all don't carry that. That's something that we can give them when they get to the hospital. But what we can do is give them rack epi, and it will turn a kid around really quick. And so I've seen kids go from very unwell to sounding totally normal after getting a rack epi neb. And another thing that's really important is keeping the patient calm. So, if you can let the parents come in with transport to keep them from, freaking out the whole way. These kids, as they get more agitated, their obstruction is going to get worse. And so trying to find a way to keep them calm, letting them get comfortable because they may be positioning themselves to open their airway. All of that's super important. And so how do you, if you don't have like specific rack epi, how do you make a rack epi neb? Close. So if we all seem to have the 1 to 1,000, we don't have the other one. So you'd use you're going to use the 1 to 1,000 for this. So it's 0.5 mLs per kg. Most of these kids are going to be kind of in the toddler age, and so you're probably going to already go up towards like the normal 5 milliliters. If you're having like a really small kid that you're wanting to give rack epi to, you would just fill it up to make 4 milliliters, and so you'd add saline for whatever you're not using of epi. And so you can give up to 5 mils of this 1 to 1,000 and just nebulize it like you would albuterol or anything else. And this can pretty much, turn them around if they're in severe distress.
So, Doc, would you add any saline to that? You may.
So if you're not going to use the full 5 milliliters, I would dilute it with saline to get at least 4 milliliters of the solution. So if let's say you have a kid that's, I don't know, 4 kilos and you're given 2 mils, I would have 2 mils of saline to get a total of 4, if that makes sense. Moving on to another case. So we have a 76-year-old male, history of heart failure with reduced ejection fraction, really severe, less than 20%, has hypertension and diabetes as well. He says, I've been a little bit more short of breath over the last 3 days, really worse today, so I wanted to call. Heart rate's 95, blood pressure's 150/76, respiratory rate 26, oxygen saturation 91%, temperature is fine. You are doing your exam, you notice that they've got, some edema in their legs or labored breathing, you're listening to, and you're hearing some crackles in their lower lung fields. What else do you want to know? Yes, he does. Yeah. It's been a couple days. I don't like going to the restroom all the time, so. Exactly. So you're already like nailing it. Yeah. So this patient has a CHF exacerbation. most likely diagnosis is that. His heart is just not hearting, it's not squeezing. So on the left side of the screen, you can see kind of someone with a grossly normal EF, and this will be our patients over here, just really working hard, just not hardly moving at all to squeeze. And so pathophysiology of cardiogenic pulmonary edema, which is what our patient is experiencing, that's what's causing their shortness of breath, is the fluid on the lungs, is that you get, backup behind that heart. They can't really pump as hard, and you get the leaky capillaries that start to leak out the fluid and cause pulmonary edema and give them their symptoms. So we got some IV access. We got them on some supplemental oxygen. Wasn't really cutting it. So what else do you want to do? Yes, absolutely. Yes. Yes, so I would definitely give Lasix. And so for this patient, you feel like it's like pretty slam dunk CHF exacerbation. They're telling you, I haven't had my Lasix. How much Lasix would you give them? Yeah, all of it is a good answer. Yeah, so that's a great question. So that's how I base my Lasix dosing. This is just kind of like an easy way to do it. If you or your medical director has a different way, that's fine. But this is kind of my recommendation for it. If they're Lasix naive, meaning they are very new heart failure, or they don't really take Lasix at home or they take it as needed, I would just do like 40 milligrams IV. If they are on really low dose at home, let's just say they're on like 20 or 40, then I would give 80. And then if they're on high dose, like they're on high doses of Lasix, like 80 twice a day, or they're on torsemide, or they're on Bumex, or those medications that are indicating that they are are not new to this, then I would give 120. I would, if they're looking this sick, or pretty sick, I would. Usually I start with 120 in the ER if they're pretty sick. There are actual studies that have shown that there's a mortality benefit to making sure that you have adequate dosing up front. So if you underdose them, there's mortality risk with that, and so that's why I kind of go bigger, just to make sure that we're getting that fluid off and not prolonging their hospitalization. You can also give nitrates if their blood pressure can tolerate it, and so our patient was hypertensive, systolics were in the 150s. Yeah, so their heart is having to pump against that. And their heart, so I would go ahead and just do some sublingual nitro, just to kind of help with that afterload reduction, and help their heart be able to move things forward. And then, like y'all mentioned, CPAP or BiPAP, if you're capable of that, is great. They need that positive pressure to kind of help open up their airways a little bit. So we'll kind of hurry through these last few cases. This is a 2-year-old that has an abnormal sound when breathing. Parents found them in the game room, just kind of playing with some board games. They are otherwise looking pretty okay. Their vitals aren't terrible, but you're hearing this noise when they're breathing high pitched in and out. And so what were we worried about? Yeah, so airway obstruction, swallowed that monopoly piece. So this kid is scary. And so this kid can decompensate fast. They may look good now, but that doesn't mean they're going to stay looking good. And so things to think about. There's like a little bit of a rule of we can kind of gauge where the foreign body is based off of the sound you're hearing them make. So if it's kind of higher up in the airway, you'll hear inspiratory stridor. If it's kind of like right in the area of the glottis, cervical trachea area, you're going to hear biphasic, meaning inspiratory and expiratory stridor. And as you go further down, it's going to be expiratory stridor. And so that is just kind of like a rule of thumb. I'm sure that there are exceptions to the rule. There always are in medicine, but just kind of a rule of thumb to kind of know where you're at. And if this patient decompensates, obviously you're going to keep them calm because we don't want this foreign body moving. We don't want them freaking out, let them get in a good position. But if they decompensate, this is kind of something that I would discuss with your medical director in terms of how they would want you to handle it. How I would handle this is based off of where I think the foreign body is. If I think it's higher up, once I look with hopefully a video scope if you have one, if I can't remove something with McGill forceps, then I would probably correct the patient because I know that the obstruction is above. If I can see it, just through the cords or whatever, I can try to correct them and get below the obstruction. If I'm not able to remove it and they're, if they're crumping on me, that's kind of where I would go. If you can't see it and you're like, oh, this is further down in the airway, something you can consider is taking a bougie and actually trying to main stem the obstruction. And so pushing the obstruction into one of the main stems to open up one of the lungs. So you at least have one lung you can use. And so that's something to consider. Obviously, don't push anything that if you have resistance, we're not trying to cause any injuries that weren't already there. But obviously, if the kid's, about to crash, then this is just something to consider, trying to push it into one lung so that you have another lung that you can use. Another case real quick. This patient, 24-year-old, all of a sudden said, I can't take a deep breath, really starting to hurt on one of my, let's just say my right side. Otherwise, just a little tachycardic, oxygen saturation is a little bit low for a healthy 24-year-old, breathing a little bit fast, not really hearing good breath sounds on the right. Thinking, yeah, so yeah, spontaneous pneumo. So some people, they think, oh, this patient doesn't have trauma, that's not a pneumothorax. That's not the case. Obviously, you can still get pneumothorax even without traumatic injuries. Some people are more predisposed to this. Some patients have what we call catamenial spontaneous pneumo. So patients with endometriosis can actually get endometriosis to the lung, which can cause them to develop spontaneous pneumos around the time of their menstrual cycle. And some people just get these, they just get primary spontaneous pneumos. If they have it happen more than once, then they're the more likely to continue to have it happen. But some people can get this one time and be like a one and done. If you do get access to ultrasound, I know that's like a up and coming in the EMS, like we've talked about, you can look for lung sliding. You can also use something called M mode. If you get this seashore sign, meaning it looks kind of like a beach over there on the left, that means that the lung is up and is rubbing against the pleural as it's supposed to. If you get this barcode sign, that's a sign of a pneumo. And so that's just like a quick, easy way you can just throw a probe on within like 5 seconds and know whether or not the patient's got a pneumo or not, which is helpful. So big things for this patient is what are we worried about with pneumothorax? Like, what do we not want the patient to do? Exactly. So spontaneous pneumos can develop tension physiology as well. And so big things to worry about is if they're going to progress to that. And so let's say our patient's vitals change to something like this, get more tachycardic, start to get hypotensive, then their mental status just starts to go. They're not really, they're kind of worked out. So now we're worried for tension physiology. And so you kind of, at that point, would want to look for tracheal deviation. You can kind of look for JVD and see if they have any jugular venous distension, and what intervention can we do really quickly to try to turn them around if they develop this. Yeah. 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 So pop them. So I think this is super, super important, but you have to know exactly where to do it because there are structures. Obviously, if you're going on the left side, then that could be, you could hit the heart if you go in the wrong spot. And so we don't want that. And so you just have to be really careful, make sure you really know your landmarks. And so we're going to go at the level of the sternal angle is the second rib. So the second rib comes in right onto the sternal angle. And then the space right under that is the second intercostal space. We're going to come over to mid-clavicular line, and that's where we're going to go. We're not going to go down here anywhere near the heart because if that would just cause bigger problems. And so we're going to take our angiocath and do that, and that's going to, hopefully temporize us to get to the hospital where they can get a chest tube. So to be honest, no, I probably, what do you think, Vern?
Yeah, I like the anterior approach better.
Yeah.
Was that the question?
Yeah.
Yeah. Yeah. Yeah. You just got to remember placement's key to this stuff, guys. So if you go lateral and you're going lower below the anatomical nipple line, there's a risk that you're hitting into the abdominal cavity, not just chest cavity, right? So just huge risk. The other problem is the studies that showed that the lateral side were better than the anterior approach were military and law enforcement guys that are healthy, not a lot of adipose tissue, and they also wore vests. That's not our typical patient in Alabama. People that are large, it's tough to go lateral because your catheter fat rolls fall over and stuff. If somebody's laying flat, air's gonna be up top. So I like the anterior approach, the short version. Sorry, I'm rambling.
No, that's okay. And I think it's a really good point thinking of like size of the patient. Because even like when we're doing chest tubes, sometimes we'll do like smaller chest tubes versus bigger chest tubes. And if it's a larger person, they can kink off their chest tube just with their soft tissue. So you just have to keep that in mind as well. And so I think doing the anterior approach is probably the best bet. And just do it the same way every time. Know your landmarks. So I just wouldn't, kind of play with it. If you're going to do the anterior approach, I would just continue doing that and knowing exactly where you want to go.
Yeah, so we should go mid-clavicular, third, fourth intercostal space, or second and third.
Yeah.
So high, and then the middle clavicle.
Yeah.
So if you just get one of those right, there's no chance of hitting the heart.
Yeah. So
Yeah.
just make sure you're high enough. That's all. Make sure you're high enough. Because we have seen where people have skimmed the pericardium, or and they're trying to help, and that's great. And they if the procedure is indicated, then great. But you just have to make sure you're high enough, especially if you're on the left side. So this patient, some things, this is kind of like a respiratory mimic. And so patients who have had a myocardial infarction are at risk for certain complications after they have a myocardial infarction. And so this patient suddenly develops like shortness of breath, became really unwell appearing, got hypotensive a little bit, softer blood pressures. EMS arrives, they've got crackles in their lung fields, very unwell, and they're telling you, I just had a stent placed for a heart attack a few days ago. This is going to be flash pulmonary edema from a papillary muscle rupture. And so there's some things that can happen after myocardial infarction, and this is one of them, usually 2 to 7 days after an MI. This is when you're going to be looking for this. So what happens is that papillary muscle will rupture, usually the posterior medial papillary muscle, because it has an isolated blood supply, whereas the other one has dual blood supply. And so if that blood supply was the one that was disrupted with the myocardial infarction, you may have some ischemia to it, and it may rupture. Then your mitral valve is basically toast, and you're just having this mitral regurg that is really severe and can lead to this flash pulmonary edema and shock. If these patients, and here's some of the other complications from MI, you can get free wall rupture, which is terrifying, and that can lead to like a big effusion and tamponade. Pericarditis, some aneurysm formation. So these are all things that you're going to be worried about in these patients who've just had an MI. But if they're hemodynamically stable, you're going to kind of treat them like a CHF exacerbation, the nitrates and the Lasix. But a lot of times these patients are going to be hemodynamically unstable, so you're just going to be temporizing them with the microdose epi, trying to get them to the hospital, not wanting to give them anything that's going to bottom out their blood pressure further, like the Lasix or the nitrates, unless they can tolerate it.
So Dr. Adams, would dopamine infusion be indicated, or are you preferencing microdose epi over dopamine?
I typically preference microdose epi. I think we're kind of moved away from dopamine. It is indicated it can serve as a pressor. Do you have any thoughts on that?
Yeah, so dopamine, I think, is better for hypotensive bradycardia because you're going to get an increase in heart rate. If the heart rate's okay, I would probably give the push dose, like you said. If you're thinking cardiogenic shock, then dobutamine is probably a better choice there as well. And you can do dobutamine and push dose epi, or dobutamine and dopamine. But if you need more squeeze, dobutamine, because I don't think anybody's carrying milrinone at this point in the game, except some of the flight guys.
Yeah, I didn't realize y'all carry dobutamine. That's new.
Some places will, yes, ma'am.
Good. Okay. So yeah, definitely that. You want the inotropy, and so you want that heart squeeze in better to try to get good cardiac output. And so that's what you do there. Quickly, we just have a couple more cases left. And so this is a 54-year-old, has a history of lung cancer, who's coughing up some pretty good sized blood clots, we'll say like quarter to golf ball size over the last few hours. They're tachycardic. Blood pressure is a little soft. They're statting okay, 94%, a little bit increased respiratory rate, but she's still talking to you in full sentences. You notice a little bit of blood around her mouth. When you're listening to her right lower lobe, I'm not hearing a whole lot, but she's like, that's where my cancer is. So I'm not super worried about that. What do y'all think is going on? So she's having large volume hemoptysis, and so pneumothorax could definitely happen if you have lung cancer. That's something to be looking out for. If she's coughing up all this blood, especially if it's like quarter golf ball size, that's significant. And so a lot of times people think, oh, it's just like 100 mLs, 200 mLs, no big deal. But 200 mLs is enough to asphyxiate someone, and so that's a lot for the lungs. And so massive hemoptysis is characterized as greater than 400 milliliters in 24 hours or 150 to 200 at once. And so that's kind of what you're looking for, just like roughly. Obviously, you're not going to be able to always measure it unless you actively have an emesis bag that you can measure. Non-massive is going to be just the opposite. But for me, anybody who's has hemodynamic changes is going to be concerning. So this patient's tachycardic, their blood pressure is a little bit softer. She's telling me a pretty significant quantity of blood is coming up. That's concerning. And so you're going to want to have the patient either sitting up. If they have a good cough, you can consider laying them with their affected side down, and so that their good lung is up to try to prevent the blood from going over into the good lung. Things that you can give this patient. Would anybody here want to give this patient blood if you had it? Absolutely. So I would definitely give this patient blood. I know that their blood pressure was okay, but their shock index, which is heart rate over systolic blood pressure, is greater than 1. So anybody who's having a significant amount of bleeding, whether it be a GI bleed, a trauma patient, this patient who's having large volume hemoptysis, I would give them blood. And so if you have access to that, do that. If you don't, you can consider fluid resuscitation just to try to keep their blood pressure up, because you don't want to wait until their blood pressure's in the tank to try to start resuscitating them. Also, something to consider, you can do inhaled TXA. It's 500 milligrams just into like a neb, and let them inhale it. That can try to help you kind of temporize to get to the hospital. We typically do that when they get there anyways, and so that's something that's really helpful if you want to go ahead and get that process started. If the patient decompensates, starts coughing up a ton of blood, and you're thinking, this patient's about to code, I'm going to have to take their airway and there's going to be blood everywhere. What was that? Say that one more time. Valid. Oh, okay. I'm not familiar with that, but it sounds like something suction. Uh-huh. Okay. So yes, definitely want to be prepared to be suctioned. Even if you have 2 suctions, more suction, the better for this type of patient. But something that you can think about, obviously, in discussion with your medical director, is you're going to want to resuscitate this patient, or they're going to code with RSI drugs. So you don't want to give anyone who's hypotensive, tachycardic, who needs the preload RSI drugs, because they will code. You also are going to want to have some like push-dose epi or something ready to try to resuscitate them after they get the drugs, because they're probably still going to try to crump on you, even with resuscitation. I would attempt a main stem intubation for this patient. So you're going to want to, if you know which lung is affected, if they're telling you, I've got tumor on this side, you're listening, that's where you think the blood is coming from, you can attempt to main stem. Obviously, that's easier said than done sometimes. And so main stemming the right is going to be a little bit more easier. Trying to get into the left, if their good lung is on the left, then that's a little bit more tricky. There are techniques that I've seen where if you're using a bougie, once you get through the cord, you're going to rotate either 90 degrees this way if you're trying to go to the right, 90 degrees to the left if you're trying to go into the left lung, who've had pretty good success with that. But that was on a cadaver model. And so who knows if that's going to work in a situation like this. But it is something you could try just to, try to protect the good lung. You could have them balloon inflated to try to limit as much blood as possible to getting into the good lung and still be able to ventilate the patient, at least to get them to the hospital. Classic cause of hemoptysis in a trach patient. It could be that. But a tracheoinnominate fistula is a terrifying complication in trach patients. Trachs are typically scary for people anyways, just because, that it's different than what we're used to. So a lot of people are fearful of trach patients to begin with. But a bleeding trach patient, oftentimes when they're bleeding, it's, they've suctioned or they've, something's kind of, like y'all said, yanked on it, something like that. But if they're having a significant amount of bleeding, that's something else. And so this can happen where you get a tracheoinnominate fistula between the trachea and the innominate artery that kind of runs right along the front of the trachea. And what happens is the trach kind of erodes into it either through the stoma or through the actual trachea itself. And those kind of see in those illustrations there. And you're going to want to try to tamponade the bleeding, but it's going to be kind of hard. Does anybody have any ideas of what you could do to try to stop them from bleeding temporarily? Yeah, so you could overinflate the cuff that they have on their trach. So some patients have their trach cuff down to begin with. Some of them have it inflated. It's important to ask whoever's with them if they're trached. I'm assuming that they have a caregiver that's going to be there to give you some information. If their cuff is down, you could also just investigate the trach to see if the cuff is up or down. Then you're going to want to inflate it, and then you're going to want to overinflate it. Be careful though, because if you pop it, then you're also screwed. And so another important question is always asking if they have an extra trach. Any trach patient you take care of, getting the extra, because they're going to usually have an extra, is helpful because they may not have the same trach as what they carry at the hospital you're going to. It's always helpful just to have an extra. If you've popped the cuff, then you have another one as a backup. You can overinflate the trach, and usually this is about 85% effective at tamponading off the bleeding. Or there's something called the Utley maneuver. This would be like a last ditch effort for me. I wouldn't do this up front. So this is going to require you to intubate the patient from above. So you're going to have to know whether or not that can happen based off of why they had the trach to begin with. And then if you can't intubate from above, this is when you would actually put your finger in the trach stoma, and you're going to push down against the manubrium, against the sternum itself, to tamponade off that artery. So you're going to go in and pull against the sternum, and that's going to kind of wrap your finger around that artery and tamponade it off. And that's just to kind of, hold it. You're going to hold it there until you get to where you need to go. That's just temporizing them to get them to the hospital. Yeah, so me holding the whole time. And then the last case I have, 54-year-old, recent pacemaker replacement, tachycardic, soft blood pressures, breathing pretty fast, borderline oxygen saturation, looks bad, has descended neck veins. What else do you want to know? Anybody have any clue what's going on? What if I told you they have terrible JVD, all of their veins, you can see the veins in their head? What'd you say? Yes. And so patients with recent heart surgeries or procedures are at risk for tamponade physiology. And so while it is rare, they can develop a pericardial effusion that leads to tamponade. So if you were able to ultrasound them, you're going to see this diastolic collapse of the right ventricle. When it should be filling, it's not filling. And so that's just from the pressure in the pericardial space from all the fluid. And what things can you do for these people to try to temporize them to get them to the hospital? Yeah, oxygen and preload. So preload. These patients need fluid to kind of overcome the pressure that's being put out on the outside of the heart. They need fluid going into the heart, kind of putting more pressure to kind of keep the cardiac output going. So they need all the fluids. So you're just going to keep giving them fluids, obviously not like 4 liters or 5 liters, but you're going to be giving them fluids and try to get them there. And what they really need is a pericardiocentesis, which can happen once they get to the ER. But to try to temporize them, you're going to give them as much preload as you can, and oxygen, definitely. And then that's just a little bit about how we do the pericardiocentesis. Just kind of going subxiphoid with a big needle and draining it out. You can see it on ultrasound, use ultrasound guidance. And usually they kind of bounce back pretty quickly once you're able to get the fluid out from around the heart. What questions?
Very good. Thank you, Dr. Adams. We've got one I've had on hold for a while, all the way back to the pulmonary embolism case,
Okay.
which is an interesting question, is why don't we stress giving aspirin if we have a pretty good or very high index of suspicion for pulmonary embolism? Anything wrong with giving them aspirin?
That makes sense. I would give them aspirin. Yes.
Yeah. So, I think there's nothing wrong at all with giving them aspirin. I can't think of a reason not to. So, kind of building on that question, Dr. Ferguson, we're talking about maybe introducing in the future at some point some lytics pre-hospital Retivase, I think, has been thrown around. Are lytics used for pulmonary embolism clinically?
Yes. Yeah. You use TNK or you use TPA. At academic centers, you can go in with like you do a heart cath and go to that pulmonary artery and squirt low dose of thrombolytics there. So there's a potential for that for field use in the future. I think that the potential for STEMI is greater because there's more objective data that we can find to prove it, right? But yeah, there's potential for that, yes.
All right, very good. So the other question that came in from the online crowd was way back several cases ago on the child with croup, the croup. You described Strider and croup, and essentially the comment is, hey, didn't think that croup made Strider. I thought that was epiglottitis. And I think that is the way it's usually presented academically, but I would say don't narrow your suspicion based on one sign or symptom.
Yeah, no, I think absolutely croup causes Strider. I've seen it a lot of times. The kids who are really sick are the ones that are going to have it. They don't always have Strider though. So I think the kids who are well appearing, who are having like the barky cough, who aren't having Strider, are the ones that are going to fall in the mild section of that croup severity scale. But if they're having Strider, specifically having Strider without any agitation, those are the kids that you're going to be more worried about.
All right, very good. Anybody here in the classroom have any questions for Dr. Ferguson or Dr. Adams? Dr. Ferguson, you have anything to add?
Yeah, just a couple quick things. One, you were talking earlier about the antibiotics for pneumonia or sepsis. I think if you're going to do that, make sure your medical director's cool with it. I also talk to the hospitals you go to. It screws up some of their metrics, which doesn't really matter from a patient care standpoint, but from a billing standpoint, the hospital can mess with them. So just to keep everybody happy, I would discuss that with them. I think the bigger key for concerns for sepsis for a patient needing antibiotics would be is that when you get to the hospital, say that. Once you get triage in, find that doctor, hey, this patient is septic, use that phrase, and that keys them into, oh, now I have a time frame of metrics I got to do, or my billing reimbursement is different, right? So that just motivates them. It's sort of like if you got a young female with belly pain and you're concerned for ectopic, don't go find that doc and say, hey, I got a 19-year-old with abdominal pain that's a little bit hypotensive. You go find that doc and say, hey, I got a 9-year-old with an ectopic pregnancy. Same thing, you say the word sepsis, just gets them motivated. You had talked about the pulmonary edema from a valve rupture. So when I think about murmurs in the ER or the pre-hospital setting, the only 3 murmurs I get concerned about. One is somebody that's in pulmonary edema or a STEMI having a murmur. I think a valve or muscle rupture, and they need more than just a regular cardiologist. They need a place that has a CV surgeon as well. So it may change your thought on destination. The other murmur would be a murmur in somebody that passes out. You think about hokum, right? And then a murmur in somebody that has a fever and a rash is somebody with endocarditis. The rest of the murmurs from an ER standpoint, super interesting, but I don't care. I guess I shouldn't say I don't care. I do care, but it's not going to change what we do. There you go. That's a good, yeah, not clinically relevant. There we go. Yeah. With the asthmatic, for the critical care guys, the flight guys out there, a great drug for asthma, bronchospasm is ketamine. If you don't have ketamine, propofol works almost as good as ketamine. But remember, you should not be giving ketamine and propofol to an asthmatic. And unless in your mind they're dying, because if you make them slow their breathing down, they get worse. And you try to put them on a ventilator, they're hard to manage. But my last ditch go-to for that bad asthmatic is IM epi, line, neb treatments. I'm giving MAG, I'm giving steroids. They become altered, unresponsive. They're not ventilating well. They get more IM stuff, and they get a bunch of ketamine until I get an airway, until I can get them to a place that has more advanced medications, things that you can they can get by inhalation that you can't get in a regular ER, right? Yeah. Yes, I would use that, and I would use that to sedate the mess out of them, and I would go highest dose as I can, because it doesn't last long. 1-2 mg per kilo every 15, 20 minutes till you run out. So, oh, and the last thing is an inappropriate statement. The procedure that you mentioned, the Utley, the new name that I'm gonna use for that is called the JBBFF maneuver. So JBBBFF. And if you can
tell us what that stands for.
No. If someone tells me, I got a prize for them though. So.
Okay, all right. We're gonna reveal the prize now, or you have to.
No. You have to email in and then submit it, and I'll get you a prize. It's a JBBFF maneuver. JBBFF.
Okay. All right. That'll be fun. Hey, thanks everybody for participating today. We ran a little bit over. Sorry about that. If you're online, you can access the attendance form. There's a link in the chat box. The password for today's attendance form is Winston with a lowercase w. It is case sensitive. If that doesn't work for you for whatever reason, you can send an email to alabamaemschallenge@gmail.com. You'll get an automated reply with a link to the same attendance form. Once you fill out the attendance form, you'll get your certificate via email. If you have any problems with that, you can email us at wward@emschallenge.org, and I can help you out with that, or at certificates@emschallenge.org. So thank you, everybody. If you're in the Winston County area, the Arley area, please come by and join us. We're going to have some lunch and then do a skills lab. If not, we'll see you next time. If not, at the Rocket City EM conference, which we're going to as soon as we leave here. Where are we at for next EMS Challenge, Doc? I can't think right now where we're going to be. Oh, we're going to be at HEMC, right? Region 1. Don't know if it's going to be at HEMC or the exact location, but we're going to be at Aero Region 1, Huntsville area. All right. Awesome. Thanks, everybody. See you next time.